welcome to session 6. I am Sophie Shepherd and I'm an integrative titled pain physiotherapist and PhD candidate. I am so honoured to be here chairing session 6 on mental well-being and neurodivergence. I feel particularly grateful because this is an area that really isn't just close to my heart as a clinician who works in the complex pain and fatigue space, where the need for understanding these areas is just so important, but also as an ADHD person myself. So just to give you an idea of what to expect, we're going to start the session with a short didactic presentation, followed by a panel discussion with our panellists. In the didactic session, Irene Ais, an integrative physiotherapist, will discuss the link between hypermobility, anxiety, and mental health issues. Following Irene's presentation, we will welcome our panel of experts who are sitting here next to me to discuss the collaborative strategies for supporting mental well-being. I'm pleased to be joined by Bianca Comfort, Ktie Cleary, and Dr. Louise Tofts. During the panel discussion, we'll explore some of the ideas that Irene has introduced in more depth, such as supporting neurodivergence in EDS and HSD, concepts of person-centred care, navigating a positive child and family consultation, building hope and resilience, and much more. And we're really hoping that this will be a really conversational, discussion-based session. So we're going to be keeping it, hopefully a little bit casual and interactive, and leave plenty of time for Q&A. So we've created some Slido questions for you to share your thoughts, insights, and experiences with us as we explore these topics together, and the questions will appear on screen during the discussion. We'll conclude this session with a Q&A session where the panel will answer any questions that you might have. I'd really like to encourage people to make themselves comfortable during this session. I know this is something that has been mentioned several times, but however that looks for you, so sitting, standing, moving, getting up, stretching, moving to the sides or the back of the room as needed, or even stepping out if you do need. I would also just like to flag that because of the nature of what we're going to be talking about today, it is possible that we'll be touching on some more challenging topics like distress, trauma, medical invalidation, and suicide, and that these sorts of topics can understandably be quite confronting to sit and listen to. We will be trying to keep it really light, but please, if you do feel like you need to step out and take a break, please feel free to do so. And before I hand over to Irene, I would just like us all to take a moment for us to really acknowledge someone very special. So Kylee Black, you might notice her name is still up on those slides there. Kylee is a disability advocate from New Zealand and founder of Kylee & Co and Spirit Spark Plugs. You can thank Kylee and her team for all of the fidgets and stickers that you found in your bags and the stickers that have been out on our table. And for those of you that don't have the privilege of having met Kylee, she really is just a wonderful human. And the perspective that she brings as someone living with EDS and complex disability is truly inspiring. And she really has been foundational in contributing to this session and had originally been planning on joining us here in person as a panellist. But unfortunately, as it often does, life had other plans, and she's been working with us madly behind the scenes this week to make sure we can still include her voice in this session. And we'll have a special video from her a bit later in the session, so definitely look forward to that. But for now, I know she's watching remotely, so I would love if we could all just say a massive hello to Kylee from across the ditch. So on count of 3, 1, 2, 3. Hi, Kylee. Amazing, thank you so much. And with that, I would like to hand over to Irene.
I'll take that. Thank you. Thanks, So. Hi, everyone. What an honour to be here with you. I want to take a moment to acknowledge the country that we're on. And maybe you want to join me in feeling where your feet meet this earth. Maybe even take a moment to close your eyes if that feels useful. It's been a really big couple of days, so maybe that little moment to tune in could be nice as well. I want to acknowledge the Yagara people and the Turrbal people of the traditional custodians of Meanjin, the land on which we're gathered today. I live and work in Naarm on Wurundjeri country and acknowledge the Woiwurrung people as custodians of that land. I want to acknowledge their elders past, present and emerging, and the unbroken chain of honouring and protecting country. And of course, any Aboriginal and Torres Strait Islander people that are here today or that are tuning in with us online. I also want to acknowledge all the lived experience here today, and again, anyone tuning in with us from around the world. I know many of you will have personal experience with the topic that we're all going to be speaking to today. And I saw how many of you put up your hands yesterday when asked if you'd been incorrectly diagnosed with mental illness. So I know that there is so much lived experience in this space today. As a mental health focused physio, I support many clients who live with hypermobility syndromes and experience co-occurring mental health challenges. I hear daily stories of life with invisible chronic illness and how people struggle to feel heard, understood, and to receive timely diagnosis and appropriate care. I'm led by my clients as the experts in their experience and their needs. My work is collaborative and has been shaped by most of the stories and insights from clients, fueling my passion for people-informed care. I hope that this presentation honours their experience and yours too. The principle "nothing about us without us" is a term by disability activist James Charlton and stems from the premise that policies, procedures, research, regulations, and I feel presentations such as this one should not be created for any population without explicit input from the very people that will be impacted. In light of this, I'd like to share a few de-identified quotes from clients that I work with. I feared not being able to maintain a job because I didn't have any support from health professionals. I felt not normal, like I can't handle my emotions. I have a character flaw and it's my fault that I can't fit in. Health professionals are keen to tell me what to do, but not to listen. Before I was diagnosed, I thought, what's wrong with me? I don't want to live like this. It was only when I got diagnosed that my mental health improved. I'm so grateful to be trusted with these lived experiences and to have the opportunity today to speak to this link between hypermobility and co-occurring mental health challenges that I so often see in clinical practice. So a little bit about what I'm going to talk to you about today. We're going to talk about the prevalence of hypermobility and mental health issues, potential contributing factors, the impact of diagnosis, the role of allied healthcare, and more broadly, healthcare that is psychologically informed, and best practice models of care. But first, a little bit about me and who I am. I'm an integrative physiotherapist working at Zebras Australia, and my work is mental health focused. I'm a mental health educator, and I'm particularly passionate about sharing mental health first aid education with health professionals, mind-body facilitators, and carers. I'm also the co-founder of the Limber Collective, sharing how health professionals can work skillfully and sustainably in chronic health. And then in my spare time, I'm a yoga and meditation facilitator, and I run a yoga school called the Bridge School, where I share inclusive and trauma-informed practice, which is also mind-body evidence-based. So I'll get started, and then this incredible group of people sitting behind me will help me dive in deeper into the considerations around mental illness, neurodivergence, and mindfulness for HSD and EDS. So the link between anxiety, HSD, and EDS is poorly understood by the broader medical community. Yet interestingly, many of my clients often say that they're told their experience is just anxiety. The lifetime prevalence of anxiety disorders in the general population is about 20 or 30%, and research consistently suggests that individuals with joint hypermobility have a higher prevalence of anxiety disorders compared to the general population. Estimates vary, but anxiety prevalence in hypermobile people may range between 50 to 70%, depending on the population studies and the criteria that's used for diagnosis. This means that hypermobile individuals are at a significantly greater risk of anxiety disorders. And understanding this link not only allows for more psychologically informed approaches in healthcare, but may support earlier mental health screening and diagnosis. The value of early intervention is illustrated by a recent longitudinal study which demonstrated that hypermobile children at age 14 years were much more likely to suffer from anxiety and depression by 18, impacting them into adulthood. There is a rapidly growing body of evidence confirming the psychiatric burden among individuals with HSD and EDS. Alongside the well-known link between hypermobility and anxiety, there's a growing evidence of associations with depression, eating disorders, and stress-sensitive conditions. Many people experience symptoms without validation and support from a young age, which may increase psychological risk from early childhood. Lack of awareness by health professionals is a common obstacle to accessing care and naturally impacts mental health of those people seeking support and understanding. And furthermore, symptoms can often be dismissed and, as mentioned many times, labelled as solely mental health concerns, naturally further impacting the burden on individuals. On a much broader level, I want to acknowledge that when people live unsupported, often holding the burden of invisible illness alone, this can impact someone's sense of self, their capacity for work, to maintain relationships, their activities of daily living, which are all part of the criteria for diagnosing mental illness. And because there's no cure for HSD and EDS, this can be a lifelong journey. I'm bolstered knowing that the health professionals that are here today will be taking what they learn back to their clinical practice to enhance the care that they provide. So there's also a growing link between hypermobility and neurodivergence, with some studies suggesting figures of up to 50% co-occurrence. This is fairly consistent with what I see in the clinic and has implications when considering holistic care. So many neurodivergent clients I work with feel misunderstood and overwhelmed when accessing care. An awareness of neuroaffirming paradigms, which I'll elaborate on in a few slides, focus on depathologizing neurodiversity, considering sensory needs and communication needs, just to name a few, and are vital to ensure that people feel understood and uniquely supported. And the lack of such considerations can naturally place excess stress on people's nervous systems, increase mental health symptoms, and add to the overall burden of someone's mental health when they're attending healthcare appointments. Taking an intersectional approach reveals that hypermobile individuals can experience broad structural, environmental, and individual stressors, from ableism in our broader community to some feeling gaslit by family or friends or health professionals who lack understanding about invisible illness. It goes without saying that this arrests trust in someone's own body and impairs the confidence that support is available, leading to greater burden of living with unnecessary symptoms. And of course, there is the impact of living with all the widespread symptoms that someone can experience in a hypermobile body, including but not limited to joint instability, subluxations, fatigue, just to name a few that you know. Allostatic load refers to the cumulative burden of chronic stress and life events. Overload can occur when challenges exceed the individual's ability to cope. And so often clients feel like this is their fault, that, well, I'm here to tell you that it's not your fault. It's not about trying harder. Dysautonomia, altered proprioception and interoception, and allostatic overload are really common in individuals with hypermobility and naturally can contribute to psychological symptoms. We have a growing body of knowledge that shows how persistent stress can further impact symptoms and chronic illness across the body-mind that will further validate and guide support. We know that EDS and HSD prevalence is likely to be underestimated, and despite increasingly common presentations of hypermobility, the journey to diagnosis and treatment can be challenging, as has been said time and time again over the last few days. Many may receive no diagnosis, late diagnosis, or misdiagnosis, and too often there's more than a decade or more delay in the diagnostic process. And there's a significant impact on someone's mental health and quality of life when living with an unmanaged condition. I should acknowledge, though, that for some people I meet, diagnosis isn't as important as accessing validation, education, and support. But for others, it's a vital part of not just care, but their self-identity, a label that supports self-advocacy in the community and with health professionals, and a vital label that leads to greater self-understanding and the beginning of greater quality of life, regardless of severity of symptoms. So as hypermobility syndromes are lifelong conditions, clients may work with health professionals over a lifetime to manage symptoms and build capacity. A lack of understanding of the high prevalence of co-occurring mental illness and hypermobility thus greatly impacts the experience that someone can have when they're in the community accessing care. As a mental health focused physio, I don't treat mental illness directly. I offer a mental health aware, trauma-informed, yet body-based approach for the people that I work with. And this is part of the compassionate and affirming care that I really feel is lacking in the broader provision of healthcare for those living with EDS and HSD. I also want to encourage becoming competent in crisis management and being trained in having conversations about suicidal thoughts, regardless of the disciplines that you work in order to keep clients safe. There are certain models of care that can support the psychological well-being of clients with EDS and HSD. Trauma-informed care is a framework that's based on knowledge and understanding of how trauma affects all aspects of people's lives, neurologically, biologically, psychologically, and socially. People with EDS and HSD can not only experience anxiety, depression, and PTSD through their lives, but also higher rates of medical trauma from frequent hostility and disinterest with certain clinicians. Normalising trauma-informed approaches is therefore not only vital to bolster the experience of those with a trauma history, but also to support people in the face of negative encounters with health professionals. Trauma-sensitive approaches acknowledge the sensible vigilance and potential acute anxiety of returning to a clinic to seek care following negative experiences. So trauma-informed care should consider individuals' needs and should endeavour to develop greater safety in the therapeutic relationship, to consider someone's trauma history and the impact of the clinical environment, to allow for choice and agency, to recognise that trauma can impact a person's emotions, relationships, their entire life, and therefore care really needs to be holistic. To respond to the effects of trauma in a way that affirms and validates the strengths of the individual, that avoids re-traumatizing, and from a physio perspective, understanding that sometimes touch, movement, and bringing awareness into the body just doesn't feel safe for all of us. In my clinical practice, I spend so much time ensuring that people feel safe at the beginning of our journey working together, that we establish safety as a foundation for the work that we do. The neurodiversity paradigm is a model that views neurodivergence as an integral part of a person that is not going to be cured or changed. Autism and ADHD are acknowledged as a part of an individual's identity. And it is an approach that fundamentally honours neurodiversity as a part of human variation. Neuroaffirming care can take many forms depending on each person's needs and context. It involves accepting and valuing different ways of thinking, learning and experiencing the world, and builds trust and acceptance with neurodivergent clients. Care must be uniquely tailored and broadly must consider environmental, sensory, and communication needs. We'll talk about this much more on the panel, but a few examples include centering the neurodivergent person as the expert in their experience, non-judgment and having strategies for executive functioning challenges, considering sensory needs in clinical environments, planning the ease of scheduling and accessing appointments, having options for different ways of communicating and presenting information, offering online and in-person appointments, early communication when changes need to happen, and not shaming people for demand avoidance or if communication is hard on some days. Ultimately, we want to support people to have the freedom to unmask and truly be themselves when they're accessing care, even stimming in sessions with clients, which is something I do every single day. So call me radical, but I believe that trauma-informed care and neuro-affirming care should be the foundation of all healthcare for all people, and they fundamentally comprise essential parts of people-informed care. At its heart, people-informed care is the perspective that an individual accessing support is the expert in their experience and their needs. Individuals and their support networks have the autonomy to make choices, not determined by the health professionals. I may have particular skills or expertise, but my role is in consultation and to co-create a pathway forward with people. So finally, this brings me to the importance of having a circle of care, the very theme of this conference. Of course, in order to be people informed, there must be collaboration and consistency across all healthcare providers. As chronic health impacts multiple systems, a transdisciplinary approach to care can ensure a holistic view of body-mind interactions and management. No one should have to hold the challenges of living with chronic invisible illness on their own, and no one health professional can provide competent care within their scope of practice when considering the multi-system impact of hypermobility. Everybody deserves a circle of care to provide coordinated support for their variety of needs. And it saddens me that this approach to care is rare and can often seem revolutionary when I meet new clients. It's my hope that this becomes the norm and that people living with hypermobility syndromes can expect to be truly listened to, have their experiences validated and supported in a way that upholds their unique strengths and needs. It gives me deep hope that the existence of this conference and the panel we're about to have ensures that we're moving boldly in that direction. Thank you.
Thank you so much, Irene, for laying what is an amazing groundwork for the discussion we're going to have. And I think you touched on so many important things that we're going to be able to elaborate on and build, because I agree totally with you. I think these core concepts are just so fundamental to what we should be doing as health professionals, no matter who we're working with, no matter what setting, no matter who we're working with. You know, I think these principles apply regardless of whether we're working with someone that we know is neurodivergent or may have experienced trauma. It's just really valuable. So just so that we know what to expect from the panel discussion here, we have loosely structured our discussion into two sort of subtopics. So you'll sort of notice as we go through that it will be in two parts. And then before we move into the Q&A section, we're actually going to have Irene lead us in a really brief sort of 5-minute pause reset, because this session is really about, you know, well-being and strategies that we can use. And so as much as we're going to talk about those strategies, we also want to be able to put some of these strategies in place today. So that's what it'll look like. But before we launch into that, gang, I would like to hear from each of you, maybe a really brief introduction about each of you and where you're from, what you do.
You know all about me already.
Absolutely.
My name's Ktie Cleary, so I'm a paediatric physio from Melbourne, and we have our clinic's Ocean Kids Health. So we work with a lot of little and big people with hypermobility, so from 0 to 16. And a lot of those people will be neurodivergent. So I've got a lot that I'd like to sort of share just about sensory-friendly spaces, affirming care, and just meeting the needs of every little person that might come into our practices.
Hi, I'm Bianca Comfort. I'm a clinical psychologist. I'm also autistic and ADHD and have EDS and all of the things, as I like to call it. I'm from Melbourne as well, but I run a Australia-wide telehealth practice called Comfort Psychology that just focuses on supporting neurodivergent folk with chronic illness.
So I'm Louise Tofts. I'm a paediatrician and paediatric rehabilitation specialist, Sydney, Australia. I work with a group of young people with hypermobility, difficulties with motor skills, autism, ADHD, as well as some trauma. So I've done quite a lot of trauma rehabilitation.
Amazing, thank you. Now, before we launch into our first question here, we're actually going to go straight into our first Slido question. So I'm actually going to skip ahead a little bit here. Do we have Slido question 1? No, there we go. Excellent. So I'd like everyone to just pause and have a moment to think here. And I want you to picture a health professional with whom maybe as a patient you've had a really, really good experience with before. or if you're a health professional, you know, maybe someone you admire as a colleague. And I want you to think of the one word that you would use to describe that person. Seeing a few big ones straight away. Yeah, it's amazing watching these flow in real time. So, I mean, what's jumping out at me from looking at that, I think so much of these responses are really echoing some of the things that Irene has touched on, you know, the importance of having someone who can have empathy, who's willing to listen and to validate. But, you know, a lot of synonyms for what we're talking about here, they're jumping around and my brain can't process them. But, you know, hearing, you know, people being compassionate, caring, working in a collaborative way, someone who can be honest, you know, I think these are all really consistent themes coming through. So that's really, really brilliant to see. Fantastic. So, moving on to our first question here. Bianca, I have a question for you because I know that you're a psychologist who's really, really passionate about this space, and I'm interested in hearing about the things that you feel are important, you know, in your clinical practice when you're working in this context and with people who might be coming in with these sort of issues.
Yeah, sure. Well, I think, as Irene pointed out earlier, that just the comorbidity, and firstly, the slide that Irene presented on anxiety, I just want to point out the statistics there. So, you know, 50 to 70% of people with EDS or HSD will also have anxiety. And in my opinion, I think a lot of that actually probably is better explained by neurodivergence. And really, that's not been well explored for lots of reasons that I could get on my soapbox about. But I think that when you're working with this population, you need to have that in your mind and to not assume that if someone's coming in and looks anxious or is, you know, saying that they have psychosomatic type symptoms, that you label them with anxiety straight away. So, for example, I've had a lot of referrals for people that come to me for anxiety who have actually had like POTS, for example. So they've actually not had an anxiety disorder at all. It's been POTS, but they've been referred to me from medical professionals, and it's like, oh, as a psychologist, I shouldn't be picking up a medical condition, like, you know. So I think just having this in the back of your mind that what else could be going on for this person, they're probably neurodivergent, statistically speaking. So yeah, I think just that awareness is really important. And then bridging on from what Irene said as well around neurodiversity affirming practice, I want to highlight that neurodiversity is the full diversity of neurotypes. So it's not neurodivergence, it's neurodiversity. And that's really important because neurodiversity affirming practice is actually about affirming all neurotypes. It's not just about affirming neurodivergent folk. So everyone should be neurodiversity affirming all the time because it's for all of us. So earlier, I think yesterday, someone was speaking to clinician-associated traumatisation, which is a new-ish term that was coined, and Irene had in her slide the reference, which is from Halverson, if anyone wants to look it up. A bit sad that we need a term for that, to be honest, but I think about 80% of people with EDS have experienced clinician-associated traumatisation, and unfortunately that's even more likely for neurodivergent folk. So again, another reason to be aware of these things. Yeah, that's probably what I'd start with.
Thank you so much, because I think all of that is so important. And I think I would agree, because even reflecting on my own experience working in sort of the pain fatigue space, it is so challenging when people are living with complex chronic health conditions, and we know that a huge chunk of the people we see are going to be experiencing, you know, distress. Maybe they have concurrent mental health conditions, but maybe sometimes it's actually quite an understandable distress from the context that they're in and from their experiences, and unfortunately often can be from negative experiences with healthcare professionals. And so I think the thing that jumps out at me, particularly from my experience, one of my passions is talking about, you know, how we as clinicians can help people who might be experiencing distress, or, you know, particularly as non-mental health professionals, if we do have someone who might be at the higher end of the distress spectrum, or maybe is even having thoughts of suicide or self-harm, how can we safely and you know, productively and collaboratively help that person so that they are supported. And I have a close friend of mine who's also a researcher who said something to me once that really has stuck in my brain, I think, and I really love it, because I think it comes down to the core of a lot of what we're talking about, is that you know, when we're working as a health professional, if I use myself as an example as a physio, you know, when we're working with someone, you know, we have to be the human first, health professional second, and a physio third. And, you know, sometimes we're so quick to just jump to, oh, I'm a physio or I'm an exercise physiologist and this is what my role should be, and we miss that bigger picture. And, you know, as we've already spoken about, it's so complex, there's so many different aspects of that experience. To be able to, you know, actually sit with someone and hold space for them to share those experiences and support them through is so important. So thank you for sharing that. I wondered, while we're on this topic, Bianca, is there anything that you would recommend or suggest specifically as to how we can kind of best support people in light of, you know, the high incidence of people who might be experiencing distress or some of these other things we've spoken about?
Yeah, sure. I mean, I think the Slido, I think it's gone now, but the biggest word, I think, if I caught it right, was empathy or empathetic or some synonym of that. And I do think that's fundamental. And as you said, Soph, like person first, right? And it is tricky because a lot of us are so time poor, you know, with especially, you know, like as a psychologist, I'm very privileged because I usually get an hour with someone, but, you know, a lot of you might only have 10 minutes with someone and it's very hard to spend that whole time building rapport. But that might be what you need to do. It might be a very slow relationship building and then you can get more into what's happening for them. I think something that I see a lot is that jumping into solution mode or jumping into, oh no, that might not be what's going on for you, it's actually this, or, you know, which is very well-meaning. But I think when we think about the fact that 80% of people with EDS have had some sort of clinician-associated traumatisation, most people are going to come to see you with their back up already, which is very understandable. You know, I've been in that position myself. I think we're all a bit like hesitant when we meet someone new. And so I think we need to be really patient and validate first. Always validate, even if you're like, I don't know if that's really what's going on for you, but just let them talk it out first and then build that rapport, and then you'll have the trust that if you give them something that might be different to what they thought, they're going to be more receptive to hearing you out on it. So I think that, yeah, validation is really key, which people have already picked up on. The other thing that I want to point out is I think maybe one person said autistic as like what's the, you know, word that would describe a good health professional, which I smiled at when I saw. I was like, thank you, I'm winning. But I think that that's actually really important. And I wanted to speak to a concept called the double empathy theory. Put your hand up. Has anyone ever heard of the double empathy theory? Oh, ooh, okay, great. So basically, in the context of neurodivergence, the double empathy theory, you can Google Catherine Crompton 2020 and you'll find the paper on it. It's a really good read. And basically, up until that point, unfortunately, the diagnostic criteria for autism is very deficit-based, and you know, it talks about like social emotional deficits and things like that. However, it's actually not the case at all. It's just a difference, and autistic people can be very social. We don't have social deficits, we just have different ways of socialising. And so this study looked at communication between autistic people and holistic people or non-autistic people. And so they had 3 different groups, well, it was actually 9 groups, but split into 3. And they had a group of just autistic people, a group of just neurotypical people, and then a mixed group. And they measured the effectiveness of the communication between the groups. And what they found was that the autistic group had great communication, the neurotypical group had great communication, they were equal, but the mixed group had communication breakdowns. And that was really groundbreaking because up until that point, really, the burden was always on us as autistic folk, as well, you know, you need to conform, you need to learn social skills, you need to communicate in a certain way. But what that study showed us was that actually, no, we're both just speaking different languages, and the burden is actually on both people to make that work. And so I guess the reason why I'm so passionate about this topic in healthcare is that if you've got someone coming in, so if you're neurodivergent and you've got a neurotypical client, that might be more difficult. You're going to have to adjust your communication if you've got, and vice versa, right? So being aware of these things, I think, is, yeah, quite important.
Absolutely. I'm going to just jump in because I know it's a question that will come up and I think it's a good time to answer it. I've heard you using the term autistic, and I know a common question I ask is about the preferences for person first language. Do you mind maybe talking a little bit about that?
Sure. So I guess there's a difference. There's identity first language or person first language, and across disability, there's variances. So each community has different preferences around what that is. But Generally speaking, and now this is not the case for everyone, but generally speaking, there's a preference for using the term autistic person. So the identity first. So not saying a person with autism, like we don't have autism. It's like saying I'm not a person with female, like I am female. Like autism is a neurotype, so you can't just have it. Like it's not contagious. Like so, I think that kind of is reflected in our language. Yeah.
Yeah, awesome. Thank you so much. Ktie, I'm going to throw to you now because I know that you work in quite a different setting to Bianca in the sort of paediatric physio setting. I'm really interested to hear how your experience of sort of translating some of these concepts that we've been talking about into your particular setting, and if there's maybe similarities to things that have been mentioned already or maybe some differences or unique aspects to that.
Yeah. So I think, I guess I'll speak broadly from paediatric physio, but this would definitely apply to sort of paediatric therapy settings across probably OT and sort of speech and EP domains. But a lot of the little people that we work with won't have a diagnosis. So these are kiddos that we might be identifying. They might have differences in terms of what needs they have, particularly when they arrive to the clinic, which I'll talk about a little bit later. But in terms of, I guess, our approach and how we manage any little person that comes into the clinic, we're always wanting to provide that really safe and welcoming space for however that person presents. So whether that's a child with neurodivergence, whether that's a child who has anxiety, whether it's a child who might have a connective tissue disorder, you know, whether or not that there's a diagnosis, we're wanting to meet that little person where they're at on the day and really provide that environment to foster that really safe and nurturing space. So there are some sensory sort of components I'll talk about in a little bit, but essentially we're wanting to affirm absolutely their, you know, in terms of their neurodivergence, neurodiversity. It doesn't matter, like labels to us absolutely don't matter. We're working with the person and the parent, and we're wanting to support them and provide that safe space no matter where they're at in their journey.
Yeah, amazing. And I think too, you know, you're obviously, aside from the professional setting and the context, when we compare maybe your setting to Bianca's setting, you're working in a physical clinic as opposed to a telehealth clinic.
Yep.
And I'm interested whether you have any particular thoughts on, I guess, the things that you do or that maybe others in the room might be able to do in terms of the physical aspect of their setting. You know, are there ways that we can maybe enhance inclusivity or accessibility in the physical spaces we're working in?
Yeah. So creating sensory friendly environments, this is I guess a physio and an OT domain. So OTs, you know, I hope I represent this topic enough for you as well. But what I'm always trying to create and what our team is trying to create to support any little person that comes into our clinic is a sensory friendly environment. So often kids, particularly kids after school that might come to our clinic, we don't know what's happened for them that day. Like they might have had some issues with bullying. They might have forgotten to take their lunch. They might be dehydrated and haven't remembered to drink. You know, they might have had a really crap sleep the night before. So we don't know, you know, in what state of regulation or zone that they're going to be in and how they're going to be feeling when they get to the clinic. So we're always trying to look ahead and try and manage those sensory needs. So with our little people that have neurodivergence, and I'm ADHD too, so I've created a lot of this and a lot of these sensory tools because I can't work in an environment without these myself.
Yeah.
So in terms of what we're wanting in terms of down regulation, so that's looking at things that might help the nervous system just calm a little bit when we get there. So like if kids have had a really busy day and they might be a little bit anxious, or they might be a little bit overwhelmed when they're coming to the space. You know, if we've got bright lights and loud music and we've got a group class and we've got lots of other kids and the waiting room's super busy and there's bright colours everywhere, they're going to go running down the street. So we're wanting to provide some calm essentially for when they're coming into the space. So we're in our waiting rooms, we're looking at trying to have some absolutely natural lighting. I know for one, I'm having a lot of trouble with these lights, which probably a lot of our neurodivergent speakers might have had as well. But just the warm white instead of the bright fluorescent lights, and that's also, I guess, a factor in classrooms as well. Like kids with neurodivergence have so much difficulty sitting under fluorescent lights; it's massively fatiguing. So just looking at lighting, looking at smells that might be in the space as well, looking at temperatures. Is it too hot? Is it too cold? but giving them somewhere to access and somewhere to meet that sensory need. So often little people might need a lot of movement when they come into our space. So we've got access to proprioceptive swings, we've got access to things like peanut balls for kids to get some of those wriggles out they might just be needing to regulate their body. Or we might be finding an option for access that's calming, so that might be something like a beanbag where they can get that full body rest because they've got a really bad headache, or they've had a day where they've just had so much sensory input, or they might be feeling a certain way. So just thinking about in our clinical settings, if you do have a space, about what sort of accommodations and learning about what those things are, because essentially if a child or an adult is coming to your space and they're dysregulated, some of these tools might be the key thing they need to be able to regulate, to be able to actually feel safe and to have that connection with you to start participating.
Yeah, absolutely. Thank you so much. I think there's so many gems in that no matter where people are working, health professionals in the room, there are definitely going to be some things that we can take away. We're actually interested though in getting the audience's input on this, because one of the things that should hopefully be coming through from everything that's been discussed so far is just how everyone is completely different. And so what accommodation looks like for one person might look completely different for the other, and we can't make assumptions about one thing being the right fit for everyone. So we're actually going to go to our second Slido question now. And I would love to see your suggestions. If you have a think about one thing or one change that would make care more accessible for you, we would love to see those suggestions. Take a moment to think about it if you need to.
So while you're doing that, just one more tip. So I have a very full run sheet in my day, and sometimes families arrive very late. But I know that family's going to be very stressed, so I actually deliberately let them wait in the waiting room for 5 minutes, even though I'm behind and my anxiety is increasing, just because if you've sort of rushed and panicked to try and get to an appointment, you're running late, you've made 2 phone calls, you just need a moment to breathe and
absolutely
have a drink and calm.
I think we underestimate as clinicians the impact that we have on patients too. So if we're rushed, there's nothing worse than sitting waiting for an appointment and having your professional run out and grab you, and they're visibly stressed as well. It just really sets the tone. So I think that break is great, even for us as well as for patients too. So having a look at some of the insights here, I'm seeing clinicians running on time. Affordability definitely is something that comes into it. Having upskills in training, quiet spaces, active listening. Fantastic. There are so many suggestions here. I'm looking forward to being able to come back and have a good read through these, because there's so many tactile furnishings. Having the sensory space modified. Easy parking,
This is such good suggestions.
I know, I'm just sitting here.
We need it.
I could sit here watching this for the next half an hour and be quite happy, I think. No fragrances. And I think so much of it depends on the setting a little bit too. It's interesting reflecting on some of this stuff from a pain and fatigue perspective, because, everything we've spoken about, we know with any complex health condition, but particularly when we're talking pain and fatigue, everything is so multifactorial. And I think the thing that's becoming clear is that we really have to be able to zoom out and kind of see that whole person. And coming back to this idea of how do we best optimise care for people and how do we meet people where they're at, I think is so important. We might have our professional agenda as to, the sort of therapeutic goals that we think might be good, or the sort of intervention we want to do. But if someone comes to see us on a day and they are, visibly distressed, or they've just, life happens. Sometimes people turn up and they've had an awful day. Sometimes actually the last thing that they need is maybe the exercise program that we'd initially planned on. Sometimes actually just being able to stop and pause and actually say, look, what do we need? What do we need in this situation? And how can we get the most out of this time to best support you moving forward? I think some of the reflections, I love that you brought up the fact, your own experience with it too, Ktie, and how you found some of those changes have benefited you. Because
I have a funny little story that my colleague will laugh at. So this is before my ADHD diagnosis, which was 2 years ago. So we've got this beautiful clinic, and it's got really big windows at the front of the clinic. But I can't get natural airflow. That's one thing that I'll work on. But the lights just in the clinic used to drive me nuts. So we had these big, long, the vertical, Venetian sort of curtains. It was too dark in the clinic, and everyone complained. I'm like, okay, so we got rid of them, and then we got this sort of like translucent film to put on top of the windows just so that sort of blocked out. And I just was so fatigued at the end of the day. So I think that's something to acknowledge with people with neurodivergence and hypermobility syndromes, the amount of impact that sensory processing has on fatigue, which is something that's poorly understood, and that's just such a huge factor. But the lighting and the what we had to put on the windows was actually for me, and I changed it 3 or 4 times. So we got one other type of blind, and I was like, no, it's still not a problem. We'd have meetings in there with my colleagues, and they're like, what's the problem?
Yeah.
Like, it's absolutely fine. I'm like, how is that not bothering you? I need sunglasses in here. And then we eventually found some blinds that worked, and then when I got my diagnosis a year or 2 later, I went, okay.
Yeah. So much makes sense in hindsight.
Yeah.
Yeah. I think it's interesting reflecting on those sort of things, because I think one of the things that jumps out, and the thing I hear a lot as a physio particularly, when we start thinking about these sort of things, is we know that there are so many things that might make it harder for people to sort of engage in therapy. And I think, like, particularly from a pain perspective, we know there are lots of things that we might want to sort of address, and there are so many different factors at play. There are so many different things that we could do, but actually being able to navigate some of that executive dysfunction and actually working out how can we actually put helpful stuff in place without contributing to overwhelm and having it be too much. I think being able to sort of focus on one thing that people might be able to do really well, rather than loading them up and having too many things all at once, is always easy. And I think I've found in my experience working with autistic or ADHD patients that having strategies that can really specifically help with some of the executive dysfunction side of things. So, often talking to people about what the barrier seems to be for them, because if it is an issue with like remembering or making it habit, maybe a simple solution is, can we maybe set timers? I've had patients who have had like sticky notes in random spots around their house, so that when they walk through a door frame, they have to stare at a sticky note that tells them to, do something as they're going. Tying it to meaningful activity or things that are already sort of part of their daily structure, rather than having it just be like one big block of like physio exercise, which is, to be honest, I'm not sure even like holistic or neurotypical people find that entertaining. I think like it's always a battle. So bringing it back to the things that matter. And the sensory modulation, I think, particularly, comes into play. I think I've found in my experience, if we can look at that side of things, which I actually think is often missed, when we're talking about pain management generally, like outside of, this sort of space, we don't really talk about sensory load that much, but I actually think it make a huge difference for people.
We talk about it a lot in childhood, but it doesn't go away.
No.
And if we don't identify it in childhood, and we don't understand and meet the needs of the child, with sensory processing disorders, which are extremely common in hypermobility, and they don't have to be neurodivergent to have a sensory processing disorder. So I think if we're not acknowledging that as in childhood, and then we're looking at emotional regulation and mental health in adulthood, and we haven't met the sensory needs and we don't understand them, that's a big thing that can very much help.
Yeah, I think even things like pacing, we talk about pain management, and pacing is like one of the core things we talk about. I don't know if anyone has ever tried to help an ADHD person pace, but like it's a whole different kettle of fish. And I think,
work.
like, and I speak from personal experience. Do as I say, not as I do, please. But I think even just rethinking, even the strategies that we sort of accept as commonplace. Are these actually friendly for people whose brains work differently? So it might be, rather than complete rest breaks, maybe can we break it up with higher or lower demand activities that mean that people can sort of keep some momentum without feeling like they're having to stop, or setting timers to take breaks. Sometimes it's unpacking what people are doing and thinking, are there maybe activities that are more cognitively demanding versus more physically demanding, and being able to break it up depending on how they are in that moment, because there might be times where someone's brain might be really busy but their physical sort of capacity is quite low, and vice versa. So, and that's very different from everyone. So yeah, I think there's a lot of really interesting things taking away from what everyone's been saying that we can apply. I'm going to come to you now, Louise, if that's okay. So we've spoken about neurodiversity affirming care and person-centred care, particularly in more the allied health space. I'm really interested to hear from you, from your sort of more medical perspective in the paediatric setting, as to how this sort of looks like in your context, and maybe elaborating on that a bit.
So there's a slide, and I'm going to talk as well, and it's not quite the same content, but we need to be, as as aware of previous trauma as we can be. And we also need to make, I think, an assumption that people might or might not disclose in certain settings, and that's absolutely the patient's choice. So not all previous trauma will be disclosed, and probably particularly not medical trauma in a medical setting. So it's really important that for everyone there's a safe space to be heard, to hear and be heard. To keep I find it challenging to keep diagnostic, so particularly the first meeting, the more diagnostic consultation positive, because there's a lot to cover, all of the symptoms, all of the impairments, all of the disability. You have to actually get a really good understanding of what that person's difficulties are. It's always worth spending some time getting to know a new person as a person as well as a patient. We often, particularly in the context of vascular EDS, I have to ask about a family history where I know there are very likely to be tragedies in that family history. And then occasionally I've examined a patient who hasn't disclosed any mental health issues, and they've politely asked the parent to leave the room, and they're covered in self-harming cuts. Mm-hmm. And they haven't said anything. So I use multiple methods of communication. I use paper, so I use DAS as a mental health questionnaire. I use paper questionnaires. I ask families to send me information ahead of the appointment, but I allow space for people to choose how they would like to communicate with me, how they would feel most comfortable communicating with me. The frameworks around trauma, neurodiversity, they're all really key and they're all very valuable, but there's a basic premise here that this is basic politeness and respect. And everyone needs that. And everyone needs that in medical consultations, in therapy consultations, in everyday life. We need very specific skills if we're working with more significant trauma. I think when we're working with adolescents, we need what Irene was talking about, the mental health first aid. So there's actually programs teaching people how to manage a disclosure of suicide or manage a person who's highly distressed. People need space to communicate at their pace. So I tend to talk quite fast, and I actively have to slow myself down. I've got a young person with neurodivergence who's got very slow processing speed, so she can only speak at a very slow rate, but her intelligence is really good, and everyone interrupts her. And through every consultation with her, I literally sit on my hands and keep breathing and look at her mum, give her space to talk. So we have lots of people that we interact with who are living with a communication disability, and we need to be aware of those across the board and give people the space to feel confident to communicate as best they can. One of the other key things is the therapeutic alliance. So to start on a pathway with a patient that I'm going to care for a longer period of time, which I think most people do care for patients over years rather than just a few months or a single diagnostic consult. I want to get to know them. I want to actually build a social relationship with that person, not just a working relationship. So what's something called a therapeutic alliance. There's been some really interesting research on therapeutic alliance. Roger, one of my colleagues, did some research, and they looked at 3 different programs for back pain. So simple, common back pain. They had the 3 different physio programs, but they also set in 3 different communication styles between the groups. And the therapeutic alliance between the patient and practitioner made more difference to the pain outcomes than the actual choice of physio program.
That's actually the same in psychology. It's like 80% of progress in therapy can be applied to the therapeutic relationship, not the modality. So yeah, it's pretty powerful.
Yeah, so we need to make sure we have that therapeutic alliance. If you don't feel you have that, then maybe that's not the practitioner match for you. And then the planning and pathways forward are shared. So I need to know what you want, and then I can build you a framework about the things that might be most effective, efficient, and the people that you might need to help get you there.
Yeah.
The other key thing is hope. So we start with all this negative, what we call the medical history, which ends up delving into some really difficult experiences and difficult to live with symptoms, but I want to leave with you feeling that you have a path forward, feeling that you have hope, and you know what the next step is, where you're going next.
Awesome. That is just like the best segue I could have asked for, because we're actually going to move into our second topic here, which is, you know, the thing that you mentioned is really this importance of having hope. And I think when we're talking about well-being and, you know, how we can support that, hope is really pivotal. Now, I mentioned earlier that we're going to have a special message here from Kylee, who's unable to join us, and I would like if we were able to please pull up that special message, and would love to share that with you now.
Hello, how are we all today? I hope you are loving and enjoying conference so far. In typical zebra fashion, I find myself sitting in a hospital bed in New Zealand as opposed to there with all of you in person. I have been critically unwell this week, and there's nothing like facing setbacks and struggles to remind us of what we have and of the journey of Ehlers-Danlos syndrome also. Sometimes I feel like as far as I go, there are constant setbacks, struggles and trials. I won't lie, I have had to dig pretty deep this week to get through, to rise up in my spirits and to remind myself of truths. Attending Ehlers-Danlos conference has not just been a dream come true, it's been a long time in the making, and but to speak at it also is a dream come true, and to be involved in other capacities has been a phenomenal honour also. It's not ironic that I find myself presenting to you from a hospital bed. It seems a lot of my journey has been based in this space over and over, and I have in the past found myself in hospital before events, discharged from hospital to an event and admitted straight back. But it's a journey, you know. I first got sick when I was in my early 20s. I experienced the full effects of Ehlers-Danlos throughout my childhood and teens. But I found myself in a, what I would call bed-bound, though I wouldn't use those terms today, state at that point. I had lost full use of my left-hand side and partial use of my legs. And I knew that if I was going to make it, I was going to have to find a way to connect back into my community, to find my reason, to find my why. And I guess it's from there that I wanted to share a few truths that I've learnt from that journey today. At that point in time, my cornerstones each morning were, I could see the sun, I could see the lake, I could see the sky, I could move my right hand, and I had access to the internet. And my grandma always used to ask, what would you have done if you'd been born in my day? And I was used to reply, Gran, I'm pretty sure that's why I wasn't born in your day. Life would have looked a lot more limited. I was a girl in four walls, but with the internet, it opened my world. So I asked myself a question shortly after that changed the entirety of my journey moving forward. It felt like a seismic shift, and it's been a platform on which I've spoken ever since. I looked in my hand and I asked myself a question, innocent question, I thought. What can I do with what's in my hand right now? Because that's all I had. That's all I had to use. And if you hold your hand out in front of yourselves right now, with me, and move it in and out if you can, and ask yourself, what can I do with what's in my hand right now? Back at that point in my journey, I looked and I went, well, I have access to the internet, and I made it my job to message, encourage, and support others, because I realised that if I was struggling, then no doubt there were others out there that would be struggling also. And I also knew that getting sucked into the reality of my own world, I drowned, and I still drown really quickly. But if I can look outside of my world to the worlds of others, to see what I do have and not what I don't, what I can do and not what I do, see what I can do and not what I can't, and what I do have and not what I don't, then I can cope. And yeah, it's so simple. And that's what Kylee and Co. came out of as well, is that I was constantly trying to find ways to connect into community. And, you know, it started with encouraging messages, and then we started making encouragement books. And while it would be a number of years on before Kylee and Co. started, it started right back then. And life isn't linear. It's not a linear journey. And there's been so many struggles and trials since. And once again, I found myself in a long period of hospitalizations, 2 years of being admitted more in than out, desperately trying to connect into community, stay connected into community, and find what I could do. Because everyone was quick to identify what I couldn't do and what I didn't have, or how tragic my life was. But not a lot of people took time to go, but what can you do and what do you have? And I have a now phenomenally incredible partner and family who rallied around me and helped me find the spaces that allowed me to thrive, and which then allowed me to start to support others to find spaces where they thrived. And we now lead a community for others in situations like myself who are isolated or disconnected or need supports in different ways to go, what lights your heart, what lights your soul, what fires your spirit, and what do you love to do? And then how do we create opportunities of inclusion for that? Because there's still lots of things that I can't do, but there are also lots of things that I can. And armed with a phone now and a hospital bed. And even at home, I have a hospital bed at home, a big double hospital bed that I call the Palace. And I base myself from there. And from there, I'm able to connect into community and with others and design and provide products. And a lot of the products, the stickers, the posters, the bracelets, have all been designed by EDS youth and vendor and community. And we're creating community to get behind and support one another. Because the reality is, none of us can do this life alone. And if Ehlers-Danlos teaches us anything at all, is that we all need each other and we all need support. But we all have strengths and things we can give as well. And the other thing that I've learned through my journey, that goes right back to those early days and earlier still, is that one step at a time, and soon enough when we look back, those steps turn into miles. You know, we don't get to the big lofty places with one big jump. It's the small tiny steps and moments that get us to where we want to be. And soon enough we've come longer and further than we ever thought. And that is something I hold on to in every trial and setback, and every good day and bad, is what's in my hands, what can I do with what's in my hands, and make that next tiny step, and what can I do to brighten someone else's day. And so I also just wanted to take a moment to thank you all so much for having me via video link. I really appreciate it, and I hope that you got something out of my short message, and something to leave with you is just that question again with your hands of whether you're a health professional, whether you're someone living with Ehlers-Danlos or supporting someone, is what can I do with what's in my hand right now? and alone we get so far, together we get so much further. Thank you all so much.
So good.
So good.
So I think we can all agree, like, there's just so much that all of us can take from that regardless. I think there's just so much beauty in that, and a big thank you to Kylee for organising that madly. While she's clearly had a lot on her plate this week, she really took the time out to organise that and went above and beyond. So big thank you. We've got a little bit of time before we go into our brief reset and Q&A. Just a couple of questions before we do that though. Bianca, I'm interested if you can briefly touch on, you know, in your work with in this space, how do you see hope and agency playing a role, especially when people might be moving through some of these sort of complex systems, health systems and disability systems?
I feel like Kylee covered that, to be honest.
Yeah.
I think it's critical, really, isn't it? Because if we have no hope, then what are we left with? I think centering lived experience is actually quite vital to hope, because we can look at people like, you know, we've heard from Kylee, and she's shared her story, and look at what she's achieved. I mean, she's sponsored this event. We've got all these beautiful gifts from her, and she's, you know, in New Zealand, in a hospital bed, still able to do that. So I think, yeah, it's really about knowing that it's possible to live a rich life, it's possible to live an authentic life, that you don't have to fit into a certain mould, into a certain box. Yeah, you can be yourself, and I think that lived experience and centering that helps us to see that and have those role models that is okay, and that we don't have to be a certain way, we can just be ourselves.
Amazing. And Irene, I know that you obviously do a lot of work in this space, and, you know, thinking through a common question I would get would be, you know, what sort of strategies might people be able to use from a, you know, maybe sort of mindfulness meditation type things, but just practices that can actually help with nervous system regulation. I know you're going to take us into a bit of a pause in a second, but I'm just interested if you had something to add around, I guess, what might influence, you know, the sort of practices that you might use with someone, or, you know, maybe if certain people might respond differently to different styles.
Yeah, absolutely. I mean, how many of us here have been told we have to do mindfulness? I'm just curious. Who likes doing mindfulness? Yeah, exactly. I think it just points to the fact that there is no one way to regulate a nervous system. There's no one way to support our sensory needs. We keep coming back to that, I think, as like a foundational idea today, that we all need something different, and all our nervous systems need something different. So some people I work with genuinely feel that pausing for a moment and coming into presence in a non-judgmental way, if we think of the definition of mindfulness, is really useful. They feel a little more here, a little more connected, a little more in the moment. But for other people, that feels difficult, especially because there's so much stigma and load around. To be mindful, you have to have no thoughts. To meditate, you have to be completely calm. I want to really call that out as not correct and not true and not relevant for most of us in our experience of what happens in our minds through the day. So yes, mindfulness is useful, meditation can be useful, but so are body-based approaches. Something that's more somatic, like hugging your cat or your dog, if your cat will let you, but going for a walk. For some of us, it's using stim toys. For others, it's co-regulating with somebody else. And I think what feels most inspiring in the work that I get to do is having these conversations to broaden someone's idea of what they have to do to be well, to live well, to progress with hope into the future, to actually flip that and say, well, what do you want? And what already works for you? And to empower that most of us already know what works for us. And maybe we just co-create more strategies and more of a rhythm in accessing what already works, rather than reinventing the wheel and having to learn something new that doesn't feel right for us. Yeah.
Absolutely. And Ktie, I'm interested, you know, because we're talking about adults a lot of the time, or, you know, I know I often work with adults, but when we're talking about kids, like, is this the sort of stuff that you see as being important early on too?
Yeah, absolutely. I think just going back to the theme of hope, really the key to hope for a lot of people is having someone listen to them and validate them, and having someone actually understand their needs. and whether that's, you know, getting an early diagnosis, which I'm extremely passionate about, and hopefully we're all able to get better at that, but that being able to meet their needs, whether it's their emotional need, their sensory need, but identifying those needs early, because a lot of the kids, particularly if we're looking at, say, school classrooms, the kids that are having difficulties with emotional regulation all have unmet needs, and if we don't know how to identify those needs early on, we're not able to then foster that, I guess, that self-awareness and that reliance on how do I meet my own needs, because eventually everyone figures themselves out. We're all completely different, and we all have completely different needs on different days. So I think just validating the little person and actually listening, and maybe even listening by observation. So it might not be they're able to tell you what they need, but look what they're doing. You know, if they are on the move and they're seeking a lot of movement, they probably need more pressure. They probably need some hugs if they're tolerant of that, or they probably need some weighted products, or they probably need, you know, we don't know. It might be ask their parents, which is the, you know, the key people. What do they do at home to meet those needs? So I think, yeah, just validating and listening as the forefront to our little people.
Yeah, so I had a little fellow once and he said, oh, I need to run. So we went out onto the oval and I got the medical history and he's running. That's okay. That's what you want to do.
So you raised a good point. You know, everyone's really different, and I'm interested if members of our panel are happy to share, maybe if there's a particular strategy that maybe you guys use in your day, whether it's, you know, it could be anything, but I guess any sort of, I guess, regulation strategy or accommodation or habit that you find helps maintain your own well-being. Would anyone like to share?
Yeah, I'm happy to go first because I have so many that I love to geek out on. I mean, for me, being in my garden is just like a haven. It grounds me instantly. But for the health professionals in the room, I find resetting between each session is really important, and something that we seldom do, or I didn't do for the first decade of being a health professional, and I like to shake it out. It's really weird, and I think it also brings a little bit of joy into the client session to just like shake things and move things out of your system and make noise and sigh things out. I find that really grounding, and like it opens the pressure valve, and I think that's useful for many people.
Yeah, I find if I'm too far away from the water or I'm out of the water for too long, I'm literally like a fish out of water. I'm totally frazzled. There's something about submerging in any sort of water, but particularly salt water. So any of my grounding activities are going to the beach with my dog, surfing, anything like that, but not having access to that, having a cold shower.
Yeah, I struggle to pick one for this.
Yeah.
But I've got like singing in the car because I find that that's alone time. It's a controlled environment and I can just be really stupid and ridiculous and no one's watching.
So I love my yin yoga. It's a 60-minute session and I can focus for about 10 minutes, but I'm building myself.
Amazing.
Otherwise my mind's everywhere else.
I love that. So
yeah, working on it. Ask me again next year.
Absolutely. I just love that there were all these very like sophisticated, detailed strategies. And the first thing I thought of when we were planning this bit was just like, I just love hugging my dog. By the way, that's my dog. That's Grover. He's a very large 40-kilo golden retriever, and I cannot tell you how long I have been waiting for the opportunity to insert a photo of him in a professional presentation. So thank you very much for that privilege. Wonderful. So before I hand off to Irene for our quick 5-minute reset before the Q&A, I'd just like to skip to our last Slido question. And I'd just like us all to take a second to pause and think, if you could take one insight, strategy or action away from today and apply it in your own life, what would that be?
Breathing's pretty important.
Yeah.
Love that.
Yeah.
Amazing.
Amazing.
This is so good.
Yeah.
Excellent. As these keep
Warm lights.
coming in. Yeah, absolutely.
Yeah.
As everyone is finishing that off and as those answers keep rolling in, Irene, I'm wondering if you would like to lead us in a bit of a reset.
I'd love to. So let's practice what we preach. Let's do a little reset. I'll guide us in a moment into a grounding exercise. If you know that tuning in isn't useful in your system, maybe you stand up for the next few minutes and move your body and do whatever feels right in your experience. I want to really invite you to not listen to a word that I say and just have your own experience if you know that that's what you prefer. But otherwise, I'm going to scooch forward in my seat and feel my feet on the ground. One of the things I really like is inviting people into a mindful experience without the load of closing the eyes and clearing your mind and having no thoughts. We're throwing those expectations out the window. So whether you're standing or whether you're sitting, just notice where the ground is supporting you, this point of contact that is always there, and start to give your body to the earth. No matter whether our mind is in the future or the past or we're present, this earth is always holding us, this land is always supporting us. And so it's such a potent place to find an orienting moment, that we're here in this moment because we're tuning into where the earth is supporting us. For some of us, where the seat is supporting you. And so feeling that, and that the more supported your body feels, perhaps the more you feel you can let go. Maybe it's the first time today sort of tuning in and noticing if there are any areas of tension, or maybe you were holding your breath a little. Just tuning into what's here in your system, however you experience that. You could just naturally watch the way your waves of breath roll in and out. Or for some of us, if you're interested in deepening your breath, you could start to breathe in for 4 or 5 and breathe out for 4 or 5. Just see if you can follow that. Again, you'll know really quickly if that's useful. Some of you are eyes closed. Some of you might be eyes open, just steadying your gaze in the room or on the earth. These tiny moments where we just get to tune in can give us so much information for us to be able to take what we need. So maybe we'll linger here just for another minute or so. So just choosing where you're at, whether you're standing, whether you're sitting, eyes closed, eyes open. Just notice that your body is supported and your body is breathing. That's automatic. You don't have to do anything at all to control that. But you have the tools in what's already here in this moment to tune in whenever you need. To be a little more present, a little more connected to yourself, a little more here. That's probably plenty for us, but I always want to say you have that as a tool to use whenever you want for the rest of the conference, and hopefully you get to take that with you too. My deepest desire is that you know there's no one way to reset and that you can make it yours. Thanks.
Amazing. Thank you, Irene.
Yeah. Oh, yeah, of course.
Amazing. So if, just for our reference up here, if we could have the timer reset just with the remaining time that we've got left, so we've got a good metric, because we had some really good discussion that I didn't want to cut short. So, but we do have heaps of questions, far more than we are going to have time for, but I'm sure that given the passion here on the panel, that if you have any questions we don't get to, I'm sure our panel would be happy to chat about it outside of this. I did see that somebody had a question somewhere up the back. Did I see a hand up here for someone that had a question? Nope. Okay, I'll read off this if that person comes back. Stick your hand up, please. Okay, so I've got one here, and I'm happy for anyone to jump in. How do we get professionals to upskill in providing neurodiversity affirming practice, given that there is such a high co-occurrence with autism, ADHD and hypermobility? Does anyone on our panel have thoughts about how we can do that?
I have a lot of thoughts on that one.
Yeah, I know. I'm sitting in a seat ready to go.
I mean, obviously I'm biased because I'm a psychologist and I'm an autistic and ADHD psychologist, so I'm like double biased. But there are a lot of amazing lived experience professionals in this space that actually do run training. So shout out, and also amazing resources. So Monique Mitchelson up the back has an amazing podcast called the Neurodivergent Woman Podcast, which has lots of seasons and amazing content. There's episodes on EDS and chronic illness and things like that as well. But yeah, really just leaning into resources and where possible, centering that from lived experience perspectives, I think, yeah. But happy to provide resources if anyone's ever curious, just flick me an email and I can send you a big long list.
Definitely. Did anyone else have anything they'd like to add to that?
I think I just want to add that wherever you start is going to get that ball rolling. Like sometimes we think we need to go to the best course for neuroaffirming care or the best course for trauma-informed care, but as you start to research, it's going to lead you somewhere. And every time you immerse yourself in one of those experiences, it's going to inspire you and it's going to tell you where to go next. So I almost feel like we can't get that wrong. Like if we're curious about being, more inclusive, then it's going to lead us somewhere wonderful.
Yeah, absolutely. Anyone else? Excellent. So maybe actually, Ktie, you kind of touched on this a little bit, so I'm going to direct this towards you first and then open it up to everyone else. You mentioned that we often think about things like sensory needs a lot when we're working with kids, but it seems to go missing as soon as people enter adulthood. Mm-hmm. Why do you think that there is such a huge contrast in that sort of compassionate care and like sort of thinking about some of these things? Do you have any ideas as to why maybe it does tend to drop off?
Well, I think probably, and look, I can't put any statistics behind this, but in terms of the rate of adults that are getting diagnosed with neurodivergent conditions, it's obviously increasing across the board, which means that we all had them when we were little, and so we were potentially, for me, the naughty kid in the class because I couldn't sit still. And then fast forward into adulthood and getting really good at masking and having the mask on all day at work and being extremely fatigued and then not knowing why. So I think probably that combination of lack of recognition and diagnosis 20 years ago, and then us all as adults, having to wear your mask every day to that environment. But I'm like so excited about this space, and it's like so accepting to actually, like now at my workplace, I can say, hey, this is what I actually need because I'm exhausted and I can't manage this much noise and I can't manage this much stimulation. So it's like I need 5 minutes to lay down with my weighted blanket and it's all good, and then I'm ready to go again. So it's just like building into some of these accommodations into like the adult, particularly workplaces, is a really big space that I'm sure will have a lot of traction in the years to come. But I think just don't be afraid, I guess, if you're an adult living with a neurodivergent condition, whether you have hypermobility or not, just to actually start putting, recognising what you need in terms of, if it is sensory things, put in some of those things and make that be okay. Mm. You have to be a little bit brave.
Absolutely.
Yeah.
I think it speaks to something that I've actually heard Kylee talk about before, where she and many other people in the disability space have mentioned it too. But accessibility and accommodations benefit everybody. You don't have to be disabled. You don't have to be living with a particular condition. You don't have to be neurodivergent. That it's just more so that maybe certain groups of people might maybe, so to speak, be the canaries in the coal mine, the stressful situations that might, create some of the issues that people face, or create stressful situations, or really put pressure on our bodies and our systems to adapt. It's just that maybe these certain groups of people may be more susceptible to that, and so we kind of talk about it in the context of that, but actually it helps everyone. I think a lot of these strategies we're talking about can help any person, any clinician, regardless of whether they're neurodivergent or living with EDS or any condition. I think they're just good practices for well-being. Mm-hmm. Yeah. Sorry, Louise, I think.
Just a very small thing. You can get sensory sensitivities in dysautonomia without having autism, so you can get very sensitive to bright lights and loud noise as part of a dysautonomic picture. Yeah. So that can change.
Yeah, absolutely. We kind of see that in MECFS and a lot of other sort of associated, even chronic pain conditions. It's a common thing, is the sensory sensitivity. Absolutely. That actually leads on to another question we had. So how might we be able to identify what our sensory needs are? Does the panel have any suggestions for ways that maybe people might be able to experiment or think about that a little bit more?
Well, this would be a call out to all of our incredible adult OTs, yes. Which is very much their domain. So particularly seeing an adult OT who has experience in managing sensory needs, which is bread and butter for OT. So this is very much something that you would get assistance from an OT from. particularly around getting a really good, like an adult version of a sensory profile administered, which is a sort of a questionnaire that will help identify exactly what your sensory needs are, but also them being able to listen to your sensory needs, because you'll know what they are.
Absolutely.
As well.
I feel like if you get asked the question, you know, but before you ask the question, it's not in your field
just
of
validates.
awareness. Yeah.
Yeah. Yeah.
Yeah, absolutely. Anything else to add?
I think sometimes, you know, especially for neurodivergent folk, I agree with what Irene's saying. Like we fundamentally know, like our bodies are intelligent, smart. You know, like someone said in one of the other talks, you know, we crave salty food. I wonder why. If you've got POTS, like it's your body trying to tell you need sodium. I think the issue, though, especially for neurodivergent folk, is that when you've lived in a society that's not built for you, you've actively had to learn to suppress your needs, and that is, you know, usually an unconscious effort, and so it can be really hard to actually know what they are. So for me, for example, like I knew I was sensitive to sound, but I didn't know how that much affected me until I wore noise-cancelling headphones to the shopping centre, and I was like, broke down to tears. I was like, oh, is this like what most people feel?
Yeah.
Like it blew my mind. So I think
Yeah.
it's not until you actually put into place some things and start experimenting that maybe you can identify. And then people, you know, there's some difficulties with that too. Like if you've got alexithymia, some people might not be able to identify that. So yeah, good healthcare providers that have an understanding of this space. And it's something that psychology can help with as well. Like if they're neurodiversity affirming too. But yeah, OT, yeah, sensory profile.
Absolutely. And sorry.
Just looking at what you don't like as well. So if the things that make you feel really exhausted, things that make you feel overwhelmed, they're generally things that you might be hypersensitive to, and generally other things that, you know, you might be seeking a lot of. So for me, it's movement. I really struggle to sit down for a long period of time. So it's that movement seeking. If I know I have enough movement, I'll be a happier, more able Ktie.
Absolutely.
Yeah.
I think my experience was, you know, I had a similar experience to you, Ktie, actually, when, you know, the lights in the clinic, I didn't realise how much the fluorescents were doing my head in until I relocated clinic rooms, and it was like, oh, my day feels so much less stressful. Nothing else had changed. It was just not having this, you know, this fluorescent going. So, yeah, it's hard until you sort of can sort of build and foster a bit of that awareness. You just may not know. Excellent. So another question that we had, sorry, it's disappeared here. Okay, this is a good question, I think, for probably everyone on the panel. How might we balance pacing for physical well-being versus pacing for psychological well-being if somebody, say, for example, used sport and exercise as part of their coping strategies, if that felt like a helpful thing? Does the panel have any suggestions as to maybe some of the things they might think about, or some of the advice they might have for how to weigh those two things up? Because it can be pretty tricky.
I mean, this is a conversation I feel I have often in the clinic, and I really love pausing to see what other strategies people have, because I think if there's, even though it's incredible both to bolster our mental health and support us physically, I would hope to arm people with more than one way to support themselves across the mind and body. And so maybe then when everything isn't hinging on being able to go for that run, you can feel like you can pace that in a bit of a better way. So I love making like a little menu or a toolkit of things that we build slowly, and I think that also helps with people who struggle with the decision fatigue of what to choose. It feels overwhelming, so the run has become the thing, and don't take it away from me because everything depends on it. So yeah, I think bolstering ourselves with more options that we either explore or that we might already have but haven't been considering.
Anything else to add to that, gang?
I think probably just around, if you are neurodivergent, like looking around, you know, what makes you really fatigued, and just using, I think Sophie, you touched on it before, but like what particular activities like might be more passive activities but might not be fully rest, because everyone says with ADHD, you need to rest, you know, my mum's always on me. You need to rest, you're pregnant, you gotta slow down, all of that sort of stuff. Like I actually physically can't switch my brain off. Like I'm a million miles, I'm on or off. Yep. So my rest is like passive activities. So it might be going for a walk with a friend, or it might be going down the beach with the dogs or something, or it might be doing something like that's an easy task to check off my to-do list. But kind of, if you are neurodivergent and you're having trouble slowing down, but just trying to even structure in maybe more of those passive activities, because when you rest, you lay down and you go into freeze mode where you're still thinking, and then you're hard on yourself because you're not getting through your to-do list.
Yeah. Rest is kind of not restful, and I think that's something that a lot of my patients resonate with as well, is that, just don't do well going through pain programs, unfortunately, because if you, just say, oh, well, you just need to stop and take breaks, it's like, but no, I don't want to do that.
Yeah.
And I think it comes back to, we want to keep people doing the things that they want to be doing as much as we can as well. So wherever we can, looking for ways that we can maybe soften or modify those so that we can keep people engaged. And maybe there are some aspects of the activity, in addition to what both of you have mentioned, maybe it's, in addition to those strategies, maybe there are ways we can sort of maybe modify that activity or soften it in some other way. I sometimes, because we mentioned, pain fatigue is so multifactorial, that sometimes there might be an activity that, from a physical demand perspective, there might be physical modifications that we can make, like doing things slower or differently physically, but we can also think about that overall load that's involved in that task. So maybe thinking about other factors that are going on at the time. So yeah, maybe physically you might be doing a similar thing, but is there maybe some sensory aspect of that we can modulate, maybe reducing down on some of the more triggering sensory experiences, or, looking at sort of other factors that might be able to be modified. So that's one other thing that we can look at.
I just want to add to that as well, Soph. I think you've touched on a good point, that it's really hard, especially when we've got all the things. And so there's often conflicting needs, right, physically and mentally. And as you were saying, like, if you're an ADHDer and people say, oh, you need to rest or whatever, and it's like, well, I'm sorry, but my brain doesn't turn off. Like, you need that mental stimulation as well. And I think recognising that that can be across different domains, so physical and mental, etc., which also speaks to the importance of the multidisciplinary collaboration. So I think having providers that can help you with each of those. So if it's a physical activity that you can no longer do, you've got an injury, or maybe you've got ME, CFS or long COVID, and you used to be a runner, now you can't do that anymore, having a good exercise physiologist or someone in that domain that can help you with modifications, or finding other strategies that can, keep you mentally stimulated as well.
Yeah, absolutely. This is a general question to the panel, whoever would like to jump in. Would anyone like to comment on working with people of colour, maybe low socioeconomic or culturally and linguistically diverse populations who might be experiencing chronic conditions, and I guess maybe when we're working in those contexts, some of the things that we might consider or how these principles might apply?
Yeah, I'd like to speak to that. I think, one, becoming culturally competent is really important, and looking at intersectionality and how different people have overlapping factors that arrest their access to care, and kind of understanding that, whether you're a health professional or not, gives us a lot of perspective on the privilege that we might hold ourselves. I want to name that I might not be the right person to work with everyone, and like those identities that you named at the start, like, even that aside, our first session is always focused on, I'm looking forward to hearing about you and how I might support you, but you get to choose whether you feel I'm the right person to work with you. And so I think that's probably even more important when we think about, different culture and different identities. And I want to name trauma in this as well, that there's an expression of, like, sometimes you can have the face of the oppressor, that if somebody isn't as comfortable working with someone of a particular gender or a particular ethnicity, we really need to respect that, and that as health professionals, we want to acknowledge we might not be right to work with everyone, and can we refer people to other health professionals who hold some of the identities and have some of the lived experience that might make that person feel safer.
I think the question had also asked about whether there's research working in that space, and I can't specifically speak to whether or not there's research particularly looking at, say, neurodiversity affirming care, for example, but I think definitely in terms of the research around I guess, the impact of this and acknowledging sort of socioeconomic circumstances and social determinants of health, we certainly have a lot of research now that really points to these sort of systemic factors as being really quite influential in the likelihood that people will develop chronic health conditions, but also impact on their likely outcomes and the success of treatments. And this is something that is gaining a lot of traction, and I think it's a really important question that has been raised. Because I think, you know, like you mentioned, Irene, that often, you know, the face of the oppressor, often we may represent, you know, potentially groups that have been harmful, or people may not necessarily inherently feel safe. And I think part of that is also acknowledging that as health professionals that we all have unconscious bias, and the systems in which we work, if they go unchallenged and we don't critically examine the systems that have been set up, there are still a lot of practices and a lot of systems in place that actively disadvantage a lot of these groups. Absolutely. And it's not enough for us to just, I guess, actively say, oh, well, you know, I'm not being, you know, overtly racist, or I'm not sexist, or any of these things. We actually need to take a step back and re-examine, you know, some of those unconscious processes where if we don't actually challenge them and we don't rethink them, we're actually just continuously contributing to this sort of ongoing oppression and inequity. So I think that's also really important to highlight as well.
I just want to add that I think we've spoken so much over the last few days around validating the individual with their experience, but how often are we validating the structural and environmental factors that load our nervous systems, that impact our mental health? And sometimes I find that that can be a real moment that shocks someone when you acknowledge that the class that someone is in, and all the ableism and the neurotypical and capitalist frameworks that influence all of our nervous systems can be a really big factor in our fatigue and our pain and our mental health. So yeah, they're big words sometimes as we're just diving into that space. There's even a really big body of knowledge now around decolonizing therapy, and that fundamentally working one-on-one with people is not accessible for everybody and is not appropriate for everybody, and that community care is as important as one-on-one therapy. And so I feel like we could have a whole panel just about that, but just to kind of name some of that as really important and sometimes really empowering. It can unburden someone to think, okay, there are some things in my life that are under my control and I can change, but there's also really big factors that impact all of us, and maybe it's not all my fault that I keep pacing and I keep modulating my sensory inputs, and yet there's still fatigue there.
Absolutely. I've got a question, and Louise, I may be interested in your take on this. We've had a question talking more about therapeutic alliance, and this person that's asked this question has highlighted that as an OT, therapeutic alliance is sort of, you know, the most important tool they might have. But, you know, a lot of health professionals might find developing that therapeutic alliance maybe difficult, or, you know, maybe there's a sort of feeling that they need to be, you know, really professional and maybe a little bit more reserved. I'm wondering if maybe you'd be comfortable sort of sharing a little bit more, maybe some of the things that you might do to aid with building therapeutic alliance.
So I was very fortunate. I got taught communication from my undergraduate degree. So we had actors come in, we had them deliberately be difficult or upset or aggressive, so that we actually got taught communication skills right from scratch. And I'm hoping that is more universal now in everybody's courses. You have to be prepared to step onto the journey with the person that you're treating. It can't be you and them. That, I don't know if I can really articulate how that is done. Anyone else? Bianca?
Yeah, I think what you've said is true, right? And it comes back to that person first, really. And maybe, you know, checking in with yourself, like if you're a healthcare provider, what is it about, like I know for me when I was a grad, there's this huge pressure to perform and to be seen as the expert and to have all the answers. And the more and more experience I get, it's like, well, I'm never going to have all the answers. No one has all the answers. And actually, like, it's good to say that, you know. If someone asks me a question, I don't know the answer, I'll say, oh, that was a really good question. I don't know the answer. I'll find out. Or where can we find out? And I think that just being humble and yeah, checking in with yourself. Like, what is it about about that experience for you. Is there something that makes you uncomfortable in not having the answer? Because I don't think anyone ever expects us to have all the answers.
Yeah, so one of the Slidos came up with the word frank from the very first question about what you like about your health. So I think it's really important to communicate back in a way people is honest about I don't know, but I know someone who does, or I don't know and I'll go and find out, and is nice and clear.
I think that honesty too, even when we start trialling interventions, for example, if we say, right, this is the plan we're going to work on, if something feels like it's not working, like giving permission and creating space where the person feels like they can be honest about that. Like, I would much prefer someone be brutally honest and say, yeah, so if you know that thing we were talking about last week, went home, tried it, no good, like give me something else. That's so much more helpful than having a space where people feel like they have to be polite and sort of, hide it and, fluff around it, because that's, never going to help people move forward. So I think they're all really good points. And I think
Yeah, and I think just in the paediatric space, one of the big words that we use a lot, but we really need to do, is play with kids. So I think, you've always got your hat on about, okay, this is what I need to achieve in the session. This is what the outcome is. Put all of that aside, and you need to learn how to play again. So that is the number one way to connect with kids. Particularly, there's a lot of robust evidence around little people with neurodivergence and their response to interventions in terms of mental health around play. So I always tell sort of our clinicians that work with us about, if you've forgotten how to play, number one is you need to learn how to play. What do you enjoy? What lights you up? What's fun? What's interesting? What's engaging? So it's not always about the communication rapport verbally, but it's about, okay, how can you get down on that person's level, particularly little people, and how can you remember how to play as an adult?
I actually think that everyone, even if you work with adults, should go spend time with the peds teams, because I actually think, I know you're talking from the peds perspective, but I actually think adults need to relearn how to play too.
Like, all of our teenagers is
everyone does.
Play-based.
Yeah.
Why not?
Exactly.
It's so much more fun.
Yeah, 100%. I think it's so valuable. So I'd like to wrap up our session now. I would like to say a massive, massive thank you to our panel and to Kylee, who's still Zooming in remotely. So thank you everyone for being here to share your expertise and your knowledge. Really, really appreciate it. And again, so many questions we don't have time for, but I'm sure that we're more than happy to answer questions if anyone wants to come find us during the breaks. This is definitely topics that we're all very passionate about talking about. So once again, thank you for tuning in, and we look forward to hearing more from you.
And thank you.
Thank you so much, everyone. Okay, I'd like to just take 2 seconds of your time. I'm going to invite up one of our board members, Ash, who is a Brit but has recently moved over to Australia and has some wisdom and knowledge she would like to share with you.
G'day.
Ash.
Thank you, over there. Hello, yes, my name is Ash. I am British, but I now live in Australia, and by way of a bit of a mission, I also work for the Australian Medical Association, leading campaigns. Earlier this week, we launched a campaign called Modernise Medicare. A lot has changed since the 80s when Medicare was launched. I'm afraid this one is going straight to the Australians. Everyone else, go have a coffee. A lot has changed, including the cost of living and inflation. We want, fundamentally, this to work harder for you when you go to the GP. We want you to be able to get the time and the care you deserve when you get there. So if that sounds like something you're interested in, please go to modernisemedicare.com.au. I have just discovered the QR code is not working. So if you could manually put that into your browser, I'd be really appreciative of it. Essentially, your voice has never been more powerful. There is a general election round the corner. And essentially, we really want you to go to the website. If you press demand, take action, one of those call to actions, it will pull you down. You can email your MP. We've put a full kind of email in there ready for you, and tell your MP you want them to modernise Medicare so that this can work harder for you when you see the GP. Thanks.
As people are sitting down, we're just going to start by introducing people on the panel. This is our panel discussion addressing the unmet needs for those living with the EDS and HSD in Australasia, which, as you've heard today, has actually been raised on multiple occasions as that there are huge unmet needs still present. So I'm Fraser Burling, I'm a rheumatologist from Auckland, New Zealand. Clifton?
I'm Clifton Chan. I'm a university professor at Macquarie University and also work privately in Potts Point, Sydney.
I'm Louise Tofts. I'm a paediatrician, paediatric rehab specialist from Sydney.
Hi, I'm Melissa Williams and I'm the Director of Zebras Australia and also the Limber Collective.
Hi, I'm Jana Link, one of the founding directors of Connective Tissues Disorder Network Australia, a patient advocacy group for individuals with connective tissue disorders.
Done? Okay.
Yeah,
I'm Sharon Hennessy. I'm the owner and director of Not Just Bending in Brisbane, and I'm a physiotherapist.
And I'm Jackie. I'm an exercise physiologist from Melbourne and owner of Dizzy Heads & Co. and also Lived Experience.
Excellent. So we have a list of questions first, and then at the end we're going to have some questions from the audience as well through the app. So the first question to Jackie with the lived experience: what are the most significant challenges facing individuals with EDS and HSD in Australasia, particularly in terms of diagnosis, treatment and ongoing care?
Yeah, so I had to make a few dot points because there's obviously many things to consider, but I think it's, predominantly the limited amount of people that are aware and also able to assess and diagnose, and like you've mentioned this weekend, Fraser, like a 5-year wait list. A lot of us who do specialise in this area do have long wait lists, and that's really unfortunate because that also impacts, I guess, the ability to access systems like the NDIS, for example, because we need to have a diagnosis before we're able to access some of those systems, which then affects, treatment and access to care, affordability of care, and then that ongoing care. So there is, the wait lists, the finances, people that are not, might know about that, but are they staying up to date as everything is evolving in this space, as we know? In terms of treatment, there is, the cost of, let's just say, MCAS meds. We know how expensive they are. How many people are on reactions, allergies, sensitivities to tapes, hands-on, clothing, compression, whatever it might be. So that, the list goes on and on. But I think there's also the, balancing of appointments. I have that for myself, but also as being a parent. Balancing all of that together, and with how busy everybody is, as I mentioned yesterday in my talk, is having to book so far in advance when you don't really know what's going on or what's going to be happening tomorrow or next week.
Balancing skills, balancing life skills, they're all really important, and I encourage those of you again who are passionate about EDS and aren't on the EDS website as a healthcare provider, please submit your names. We need all of you. Louise, how do cultural and geographic factors specific to Australasia impact access to care for people living with EDS and HSD?
Thank you. Sorry. So we're a big nation here in Australia, and we've got some very remote populations, as well as having a depth and breadth of ethnic diversity, which makes Australia our young country, our beautiful young country. The geography, so distance has been one of our major factors. We do have some schemes to help patients who are very remote access care in the capital cities as they need to. I think I still have to let patients know about IPTAS. So if you're more than 200 kilometres away from your specialist, you can get transport funding. I think 100 kilometres for some appointments. We have some cultures who have a more of a background approach where they feel that they're not given symptoms, but their symptom burden is something for them. And there's an occasion where I have to encourage people to access healthcare, or really reach out to try and get to people to access healthcare. And then delivering rehabilitation, so allied health supports out into the community It's one of my areas that I feel really passionate about. The NHS has started to help with that. We actually can now get physios and OTs to more remote, younger patients than we have been able to before that scheme. But we still need to follow through with the specialists. Queensland's better at getting specialists out to rural remote hospitals for short periods of time to network the specialist care out. New South Wales still lagging behind, and we've still got work to do with telehealth. After all that, I just wondered if we could put the Slido up, which is about you telling us what your unmet need is.
Really important, these unmet needs. And one of the things also that your statement brought up about some people not thinking that they need that access to care. Some people also, when they've been given 20 negative responses from doctors or allied health, to then know that actually there's someone who they can go to who'll be positive for them as well. This is another really difficult unmet need, how we reach those people and say, actually, there are answers, there are people that can help you. I had a lady approach me earlier today with that very issue of being told so many times that there was no hope for her daughter. In actual fact, there is hope. So helping people realise that these issues are available to, we have people who can help them, even if there is a bit of a waiting list. So that Slido question is coming up, collaborative integrative care, knowing who to trust as a treatment provider. Someone to support with the emotional side of this, absolutely. Having a support person with you is a thoroughly important thing to have. And as I mentioned yesterday, Rachel is a support person for other people, not just for her daughter as well, for people who've come to my clinic. So each of you who has knowledge and understanding, you can support others to clinics and help them get the care they need and being advocates for them too. Understanding, yes, huge one is understanding. So as they come up, we'll go on to the next question, which I'm directing to Melissa. What are the barriers to accessing multidisciplinary care in Australia, and how can these be overcome?
It's a great question, and I think it's been touched on already in this panel and in previous panels today and yesterday, but cost is a really big factor here. And unfortunately, I don't have the answer for that, but it did get me very excited to have someone up here on the stage talking about modernising Medicare. I certainly think that's a good start if we're looking at funding streams, because I'm sure a few of you would agree with me that I think our healthcare system needs a little bit of an overhaul in some departments. The second thing I wanted to touch on was the availability piece, and again, we've spoken to that extensively through the weekend. And yeah, I guess we need to be looking at training of health professionals, and we've spoken to ECHO this weekend a lot as well, is a way to connect people and to also provide that training. And then my third point was around the silos. And again, I'm saying things that you've already heard, but we need to be communicating and collaborating. And we've seen that on the Slido question, that was the very first thing that came up.
Absolutely. And that segues into the next question for Clifton. Where are the largest gaps in care for patients in this region from your point of view, and why do these gaps persist?
Big question. Where do I start? Probably as a researcher, as well as a physio clinician, I try to use as much evidence to convince both stakeholders, organisations, other doctors, liaise with my fellow colleagues, and that's really missing. And so really fortunately we were able, and thank you for everyone's support here, probably involved in a 3-round Delphi that we conducted with Dr. Alan Hadkim, Kylee Williams and Verity Pacey, that we found some of the top questions that needed to be answered in relation to musculoskeletal health in people with generalised joint hypermobility. And out of the consumer patient group, the top question they wanted answered was, how do we prevent fatigue, pain, comorbidities related to musculoskeletal problems? And the list goes on, but the top 3 questions were all about prevention. How do we do this? But as a physio, we're like, we don't have clear outcome measures to measure or a standardised way to do that that's agreed upon by everyone yet in a lot of these places. The evidence, what is the best protocol, because everyone needs to be individualised. Everyone's got a different combination of comorbidities. So there's lots of complexity there. And then we've got the healthcare practitioners. Their top questions were, how do we treat? Are there protocols? Are there, things that we can follow? And then from a university educator perspective, I look at my recent graduates and they are perplexed. It's complicated. It's really hard to treat. And they're navigating a difficult healthcare system. So some of their top questions were, how do we access NDIS for this when NDIS is always constantly changing? How do we access the public system? And we've talked about all those complexities today. So I think the biggest thing here is we need to really listen to each other. I think we've talked about that a lot, but it's actually, there is no one way to treat any one patient. We have to look at what is agreed upon, I guess, but also then tailor it for that individual. So we have to work together, and having that open communication between healthcare practitioners is the number one thing. So I think the biggest gap is we don't have a consistent, way to talk to each other. I know in diabetes management, case conferences are sort of paid for by Medicare. That's not the case here. There's no avenue for me to access public records. Like, it's just really hard. I think communication is sort of our number one gap.
Excellent. And you brought up two really valid points there. Remember, no two zebras have the same stripes. We're all individuals. Each one of you has different aspects. And while we see a big picture that shows lots of patterns, when an individual comes to meet me, I start from scratch for every single person, because you never know what's going to raise its head. The second thing is this gap of communication, the EDS echo sessions, these types of meetings, really important. And I know some of those EDS echo sessions are at early hours of the morning. I've attended at 2, 3 and 4 o'clock in the morning for them. But they are a way that I could go forward in helping people, and I know that many of you here have been attending and participating and leading these as well, and we really thank you for all that. So, and again, thanks to Alan and Nara for setting up the EDS Echo session, and we're now nearly 6 years running, so thank you for that. Sharon, with your advocacy role, how can local healthcare systems and providers better identify and address the unique needs of EDS and HSD patients?
I've always had a fairly strong focus on advocacy and training. And so I've been just working locally just to chip away at it, going to conferences, doing workshops, speaking to people. I've managed to speak to most of the Queensland rheumatologists and all the rheumatology trainees in New South Wales and ACT. POTS conference, we've have multiple presentations at the physiotherapy in-service type programs through the APA Association, the APA conference, social media, blogs, all that stuff. Just every time more information gets put out, then there's someone else who goes, oh, that could be me, or that could be my sister. And so you might have a room full of doctors and it might not resonate with many, but it will resonate with some because they will have a child or they will have it. And so then that person becomes an advocate. And from, not that I've been coming to these as long as Michelle, but in the last 10 years, I've just seeing you all here again now, people who I met 10 years ago, and saying, hi, Michelle, and people, that's where I met Michelle 10 years ago, seeing you guys come up to me again and say, oh, I remember we met 10 years ago, and since then I've been doing this, 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 and this. It's just a ball that's rolling down a hill, and hopefully as we go it'll snowball and we can just add and add and add. Also, with the help of ctDNA, I've started talking to some of the local government members, having some talks with Queensland Health, and we try to talk to the NDIS, but unfortunately they don't really listen. But we will keep persisting with that, and I think Jenna probably has some comments on that.
And actually this segues nicely to Jana as well, because the next question for you, and you're both a pharmacist and you're a patient with EDS, and you're looking at health policy as well. What role can local patient advocacy groups play in bridging the gap between healthcare providers and the community?
Yeah, so it's a big role. It's an important role and comes with a big responsibility, I think. I think the main part of it is about improving equity of access to care, but not just any care that's validating for the patient, that's best practice, evidence-based, high quality, timely and low cost. You know, I know that's a lot, that's asking for a lot, but that's, you know, the ultimate aim of healthcare, especially in a country that does have a universal healthcare system that is based in subsidised access. You know, we need to be looking at having the conversations between all stakeholders, you know, bringing them all together in rooms at the same time, and, you know, understanding the perspective of the patient, the clinicians, which is what we're doing here, you know, to identify what the knowledge gaps are, you know, how we can educate and remove the knowledge gaps, and, you know, give confidence to healthcare professionals that might not previously have been aware of these conditions to, you know, be seeing them, identifying them, you know, having them on the radar, but also just really, you know, a lot of what I spoke about yesterday as well in my presentation, it's identifying policy windows, you know, and being ready to act so that, you know, you've got the patient narratives ready to go when there is a policy window that you might be able to, you know, optimise your output, and getting in there and having the conversations with government, you know, and all of the individual stakeholders, and ensuring that the patient voice is central to everything that you're doing.
Yeah. And I think one of the things you reminded me of there is that when we're discussing with the stakeholders who hold the purse strings, reminding them that keeping people healthy is a lot cheaper than looking after them in hospital.
Definitely, yeah. And unfortunately, when you're looking across the lifespan in terms of economic policy related to healthcare, policymakers are working sort of in shorter cycles than what we're looking at. The, you know, the cost savings that are coming from the early interventions with children being diagnosed, they're not realised until you're maybe 30 and 40. So it's a long time for policymakers. So that's something that needs to be brought to their attention, that the economic savings are there.
So, Louise, as someone who is a senior clinician who has taught people over the years, what can we do to improve training and education for healthcare professionals in Australia on EDS and HSD?
So I think there are a few things. The most effective training I've provided is generally to people who are starting to practice rather than students, but we have Clifton, Verity Pacey teaching our physio students. We probably need more touch points in the EP and OT worlds to make sure those undergrad courses are getting some content. I think for practicing clinicians, we need on-demand resources. There are some on the website, but we need like immediate on-demand resources, as well as the written resources, so the published information, an actual explanation, so video lectures. These will be online, so we'll be able to come back to these. And we need a method of people being able to reach out at the time they need the information. So those central portals of information, which here in Australia has still been the society generally.
Yeah. And again, it's when you have the public health sector who say we don't want to see people with EDS, that makes it that much harder to get those young people who are new out of medical school to learning about EDS, so it can be really frustrating as well. I don't have answers for that, by the way. I only have more questions.
Yeah, and I agree, Louise. I think it needs to be like looked at from the education perspective, like medicine and allied health. Like everybody you talk to, it's like, well, medicine might have had, you know, one lecture in it, and in, like you said, exercise physiology, well, we'd never heard of it. So it starts from there, and where we can even get people to develop passion from going, oh, that sounds really interesting, it's fascinating. And then that can help us obviously have more people that want to specialise in the area. So I think that's an important piece to start from there.
And you've actually half answered the next question, which was for you, was how we can encourage more health professionals to specialise or become knowledgeable in these conditions.
Yeah.
So do you want to expand just a little further?
Yeah, I often say to anybody that will have me and listen to what I have to say, I'm happy to educate anybody. Will always say yes to a presenting opportunity, done some with the APA. I'm creating a virtual series for ESSA that's upcoming in February and March, offering supervision, mentoring, offering to present to your professional body, whatever discipline you're in, because they may not know that is something that, a speech pathologist does or an OT does. Show them what it is that we can do so that, we're putting that in front of people. And then there's, I guess, from talking from a parent perspective, but also as a patient myself, is just any opportunity to tell doctors about what this thing is, or, when I go to my son's paediatrician, I'm like, oh, have you seen this latest research? It's continuing to do that to upskill people as well. And I just wanted to link back into that prevention side of things. I've always had a real passion of going, well, without putting the fear of God in anybody, but how can we potentially present to, schools, sporting clubs? Like I've spoken to Jason Lamb about this, of even like Australian Ballet, like yes, they're athletes and things, or the, Australian women's football, for example, of where we see hypermobile people everywhere, but there's still probably some education where we can look at, information is knowledge and information is power. So bringing awareness to the importance of caring for our bodies, what might be early warning signs, particularly in, the amount of young teenagers that we see when they have, start menses and all those sorts of things, and off things go. So I think that's a way of prevention that I've been passionate in, but never had time to go anywhere with it.
It's actually fascinating how many patients go to the doctor and actually know more than their doctor about EDS. And if you've got a doctor who's open to listen and learn, you'll go a long way. If you haven't, then you need to communicate with each other about finding those who are willing to listen and learn and go a long way. I know when I first started dealing with EDS, or should I say when I first started recognising I had patients with EDS, because I actually had at least 40 patients on my books who I didn't know had EDS while it was still not on my radar. And patients were teaching me until I went to my first conference, and I had a very steep learning curve. I guess I'm here because I was willing to listen and to learn and to carry on and then help others. But you as patients can be advocates for other patients and help doctors learn as well. So I think that's really important. Jana, next one's for you. What are some of the most common frustrations or unmet needs expressed by patients and their families in this region? And this is probably a little segue on from our Slido question as well.
Yeah, I think it's primarily that there's no well-defined, ratified referral pathway, especially through the public system for HSD and HEDS. For the rarer subtypes, yes, we have genetics clinics, but the wait lists are, huge. They're prohibitively long. We're looking at 3 to 4 years in the metro areas, in the large tertiary hospitals around the world. And that's even longer when you're looking out at the rural and remote Indigenous, more isolated communities that are, often referred into the metro clinics. So it's the referral pathways, it's the wait times, it's the cost of getting a private diagnosis. And again, in that you might not necessarily I don't want to use the word successful, but you might not come away with the diagnosis that you might, the correct diagnosis, and then again you're going back to more health professionals at a high, added cost. The cost burden of being evaluated for a diagnosis is huge, Yeah. And the care coordination, which I think we've touched on a lot over the last 48 hours, the lack of care coordination, the lack of multidisciplinary, interdisciplinary clinics, the lack of qualified, aware healthcare professionals who have the skills to, provide the insights and care that's required. I think it's a lot of what we've been speaking about really over, the course of today and yesterday.
And your mention of pathways again comes on to the next question from Melissa as a supervisor as well. You may be help designing pathways. How can healthcare teams ensure that patient voices are heard and acted upon when designing these pathways?
Yeah, it's a great question, and again, it's been touched on multiple times this weekend, but at an individual level, I guess these pathways in my mind should be co-designed with the people that we're designing them for. And then if we're thinking a little bit higher, maybe at the level of policy, we have touched on this weekend the concept of nothing about us without us. We should be asking that question, who's not in the room when we're designing these policies? At a practical level, like maybe more on a day-to-day, if you're a clinician working in a clinical setting, I like the idea of using feedback-informed treatment models that can be administered before and after sessions. For us personally, we've also experimented with different surveys, and that's informed a lot of our service delivery over the years. And focus groups, I think, could also be another good and actionable idea.
Yeah. I've been on a pathway in New Zealand for helping to or design an EDS pathway, and we had patients on that pathway as well. Our frustration is only one of the then DHBs actually took it on board, and the other 22 didn't, which was really, really frustrating. But at least we got into one hospital. Now they're trying to reinvent the wheel, but without the people who know about EDS, and that's also frustrating for us also. But we still keep plotting and plugging and saying, let's do the best we can to educate the best we can.
Can I add just a tiny bit on that, on the co-design? I think it's really important. It is a bit of a buzzword, it's really an area that's increasing. All committees developing services these days have consumer involvement, but we really need to move to a place of it being meaningful involvement and not just tokenistic, being taking up a place at the table, actually listening to the voice and making sure that it is heard and followed through. Yeah.
Clifton, I understand you have an interest also in the performing arts.
Yep.
So, drawing on that, how can we choreograph the opportunities to exist for collaboration between healthcare providers in Australasia?
Very nice pun. I think I often think of being a researcher being really the medium between the consumer group and the other stakeholders like government, local health districts and all of that. So I think if we, the researchers, the university institution can be this beautiful middle ground to help facilitate meaningful co-design and actually have the patient group on the table, not as participants, but actually as designers, and then actually have local health districts come on board or even governments and asking what are their needs from both ends, and the researchers can be in the middle to actually go, okay, we are going to help you design something, or your service here, how can we improve and advance this so it meets the needs of this really important group, since we know they are definitely treating people with EDS and HSD. Jane Simmons' research in the UK has shown that at least 40% of a lot of the musculoskeletal triage clinics and outpatient orthopedic clinics have EDS patients. So from a clinical perspective, I definitely know we have that as well. And a lot of my colleagues go, I don't see them. I'm like, oh, okay, how many have you missed today?
Exactly.
So I think a good way university can really facilitate this discussion is bring all the parties on board and being that diplomatic middle intermediate point for these parties and get everyone's voices heard adequately and meaningfully.
Exactly. That's a really good answer. Sharon, back to you again. We know about ECHO as a successful model of care, but what other successful local models of care could be scaled or replicated in other parts of the region?
So I suppose if we have a quick talk about my model, which is just basically private practice focused on the physical rehab of EDS, not a multidisciplinary team under one roof. I think this model still has validity because we can be a multidisciplinary team under many roofs. Okay, so we can focus on the things that we do best and then come together to discuss what we need to change. And I think it's important. I know that that's not a funding model that's available to everyone, but it's important to show other physiotherapy practices and other single types of professional practices that if you pursue this, then you will be able to feed your family as a clinician, and that you will be able to employ staff who are well cared for and are happy and are not burnt out, because you guys are a special bunch, and it does take a little bit more time and care to look after you all. But it is also incredibly rewarding. So I think we have spent a lot of time focusing on a lot of the negatives and a lot of the burnout and the stress, but it is such a rewarding area. There are some other models that are currently in place in Brisbane. We have the Marfan's Clinic at Prince Charles Hospital, which has been running successfully for many years. Now, it does have a long waiting list, but people can go there with their Marfans and access the doctors mainly and the nurses, not so much the allied health, but they can see the cardiologist and the geneticist and bring the whole family along for assessment. The pain clinics that are run through the hospitals, the public and private hospitals, I know a lot of people here have probably had negative experiences, but their model could be replicated with a program, specifically an HEDS informed program, because they have established multidisciplinary teams, and it can be mixed with a series of inpatient stays for ketamine and for injections, along with therapy and hydrotherapy and occupational therapy. There's also some I think that's it.
Yeah. Thank you.
There's also quite a lot of funding coming through at the moment for women's health-based services, and so we are getting some quite good publicly funded women's health clinics that we would be able to piggyback onto as well. So I think you have to look, I think sometimes we're so busy thinking we don't have a HEDS service, but maybe we should be going and looking at the services that deal with the subcomponents and then seeing if we can come into that in an advocacy role. So we're not reinventing the wheel, we're just adding on to what we've got.
That'd be absolutely fantastic in the ideal world, wouldn't it?
Monday.
I think another like a model that could be replicated is like in the eating disorder space of that access to psych and dietitian and things like that. And there is an increased number of, Medicare abatable type sessions for that space, and wouldn't we just love that?
The other one I forgot to mention is the private hospital, things like day therapy. So if someone's had a stroke, they've gone home, they come back 3 times a week for all their therapies, they get reviewed by the doctor, and they pay their day admission fee, which after the first 3 times... Private health pays it. So once you pay your gap... there's no gap. So why couldn't we have that for our patients to have, okay, you've had a hospital stay, rather than have nothing now, you could have two times a week or 1 time a week and see everyone at the same time in that space with the private health funds funding. Yeah, don't know how we get that to happen. Maybe Louise can do that on Monday for me.
I did do that.
Oh, you do? Yes?
Yes.
Good. Wow, great.
The funds are, so you have to be a rehab specialist, and the funds are quite particular about the start point, so you have to have a certain level of functional impairment to go in, and they do prefer post-event. It's called subacute rehab, so they prefer it if you've had an operation, but you might be having an operation, go in for 12 sessions of subacute rehab.
Mm-hmm. There's also the Rare Care Centre in WA at the Perth Children's Hospital and Rare Diseases New South Wales. So for the rarer subtypes of EDS, they offer multidisciplinary, interdisciplinary care that also brings in, they're trying to bring in more social, so access to social supports and things like that as well, and integration with education systems and things. So yeah.
I see wonderful ideas. The only problem I see is the staff to staff them. And many people tell me you need to be cloned, and I say the same thing to all of you here. You need to be cloned to staff these things to be able to run more of them to help meet the unmet needs.
Also through universities, Melbourne University is about to start a 12-month pilot for a Stickler multidisciplinary optometry allied health clinic through the university. And being a fellow heritable connective tissue disorder, that could be a model that's worth following as well. Yeah.
So, Melissa, this question goes to you, although it does sort of lead on from this morning's technology section. What innovative approaches, such as telehealth or community-based programs, could help improve care and access for individuals living with EDS and HSD in rural and remote areas?
Yeah, I think I'm going to answer this question a little bit differently, just to pick up on the thread that we're on currently. I've been really curious myself about wraparound care models, and I know that maybe some health professionals and folks with lived experience in the room will have heard of that. These were models that were developed, I think, around the 1980s, 1990s, that were traditionally used to treat behavioural conditions for adolescents, I believe. They're strengths-based, they're evidence-based, and they're individualised, and they look to wrap the individual in support in their community. So I feel like there could be something there. I'm a big picture thinker, a bit of a visionary, so I don't know how that comes together, and hopefully there'll be some doers that could do something like that. But I really have a vision that maybe we have something like that for chronic illness and specifically for hypermobility-related conditions in the future.
So, leading on from there, Louise, what are the key priorities for addressing these unmet needs in the next 5 to 10 years? And how can we start working towards those goals? Clearly, you have made a start. So
I think we need to make sure everybody in the community is aware of the opportunities and the funding opportunities out there. Like I get asked about NDIS quite a bit. Often people aren't using carer allowance when they would be eligible. It's not very much money, but it gives you a healthcare card which drops your pharmaceutical cost, and it gives you another $100 a fortnight to pay for another allied health treatment. The Medicare safety net, and then the pain and fatigue clinics. Like they're established multidisciplinary clinics in the paediatric world. If we can, a quicker way of moving things forward might be if we inform them more about hypermobility and chronic pain specifically in hypermobility. Medicare are adding on some initiatives that involve medical specialists and then allied health. So there's something called 135, which I can bill if I'm assessing someone for complex neurodisability, and it then unlocks 20 Medicare-funded allied health sessions. The Butterfly Foundation for Eating Disorders have just got a Medicare initiative through where they can have weekly psychology. They're funded up to about 40 psychology sessions a year rather than just the 10 that anybody with a on-paper diagnosis of anxiety can get. So there might be some opportunities through federal Medicare for community-based care, which is where rehabilitation works best. And then in terms of the public hospital system's been more difficult with the big federal cost shifting that's been going on at the current time. But that's about local advocacy to those particular hospitals.
Have you been involved with the foundational supports, the starting of trying to get, as people are leaving the NDIS and they're going to see foundational support providers?
I haven't
Has anyone actually been involved in discussions? Jenna, have you heard anything about it?
Very surface level discussions at this point, yeah. It requires a lot of advocacy. Rare Voices Australia is doing a fair bit of work around that for the rare disease sector. So yeah, there is ongoing stuff happening, yeah.
Okay. Jackie, what role can attendees of this conference play in driving change for the EDS and HSD community in this region? So that's what can we get these people to do?
Yeah, well, obviously we don't want you to exhaust all of your energy in doing these things with your symptoms, but I think there's a couple of things that I wrote down is obviously as has been talked about across the weekend of, writing to your members of parliament, obviously, utilising reputable information, such as, is on, you know, the Ehlers-Danlos Society website, but for everyone else that has POTS, you know, the Australian POTS Foundation, Dysautonomy International, all of those sorts of websites, they have really good researched and reputable information, and share that information. There's, you know, if you follow particular health professionals that specialise in these areas and they're putting something up on their Instagram, share that more. Don't be afraid to share your story, because like we were saying earlier, if somebody hears your story and go, oh, okay, well, yeah, I've got a friend of a friend whose cousin sounds like that, maybe I should get them seen. You know, being involved in advocacy movements, and it's not creating something new, but maybe getting involved with things that are already established. You know, ctDNA are doing some amazing work, and we can always, you know, safety and strength in numbers. So there's that part. As Clifton said, you know, when we have, you know, questionnaires that come out, and different things like that, the more involvement that we can have in people giving that information, it gives, you know, us from this end the ability to look at, yeah, your feedback, what do you need? And that can help drive change in terms of what you need and accessing the right care.
Thank you very much. Now, we've got a minute or so for questions from the audience, and I haven't seen any questions come up on here. So with the roving mic, has anyone got a burning question? One question? Just one question? Okay.
Fraser, sorry, can I just add one more thing that's just popped into my head, as it does? I think the other great thing, obviously, that the Society's done is the core centres and networks of excellence, is finding out within Australasia, like, where are those groups? You know, reach out to them. If you're struggling to find a practitioner, or you want to ask a question, or who's the best person to see, I know myself and a lot of us sitting here would probably be more than happy to just suggest that one person, or who to talk to, or if it's a resource or a reference, you know, we're here to help and support you all as much as we can.
Okay, so I've just had the word from Nara, we have to wind up, so sorry about that. But thank you, everybody, and thank you for the whole panel for your input. It's been really wonderful helping answer some of these questions about unmet needs. I know there's a long pathway that we have to follow still to improve things, and the more people who find out about EDS and who come on board and help others, the more we grow and the more we're then able to help others. And so I hope that from this conference, many of you will go forward and will be able to stimulate others to come and listen. We've got the EDS Echo session in just another couple of months for the next Australasian EDS Echo. The International Echo series are running as well for those of you who are overseas. So thank you very much once again. Big hand.